this video we'll talk about migraine. It is an episodic neurovascular phenomena. It is called as neurovascular phenomena because it is caused by neurogenic inflammation. So it will lead to severe recurrent unilateral headache and often associated with nausea and vomiting. And it is triggered by light or the sound or the movement sensitivity. And it is mostly seen in the females and it is the second most common cause of headache. Coming to the classification, you have to remember the two main classifications. The first is classical migraine and the second is common migraine. So in the classical migraine, you can see two A's, right? So just remember it for A for aura, right? So aura is present in case of classical migraine. So this is seen only in the 20 to 30% of migraine population and often associated with heart conditions like patent foramen ovale, atrial septal defect and the AV malformation. Coming to the common migraine, there is no A in the common, so there is no aura. So what do you mean by aura? It is nothing but a warning signal before you get the headache. So in case of classical migraine, first comes the aura, then comes the headache. So aura is because of vasoconstriction, headache is because of vasodilatation. So before the onset of headache, these classical migraine people will be knowing that they are gonna have this migraine attack. Why? Because of this aura, right? So they will be feeling irritable, malaise or any visual disturbances can be seen in case of aura. So in the common migraine, there is no such thing as aura. So it is mostly seen, which is seen in 80% of the migraine population. And there is no warning signs before the onset of headache. Now let us talk about other types of migraine. You can remember it by RV, BOH, CCC, right? So the R stands for retinal. So blindness occurring less than 1 hour after headache is retinal type. And the V stands for vestibular. So the migraine is associated with vertigo. B stands for basilar. Here you can see this brainstem symptoms like vertigo, diplopia, ptosis and all. Coming to O, which is ophthalmoplegic, you can see this third, fourth and fifth nerve palsy. And hemiplegic, you can see hemiparesis, which develops after the onset of headache. Coming to CCC, the first is complicated when the migraine attack is unusually long, unusually frequent, and if it is associated with seizures, it is called as complicated migraine. And the next one is catamenial. So migraine is associated with menstruation. And childhood periodic migraine, which is seen in patients with benign paroxysmal vertigo. So these people, so from the childhood, they will be having this abdominal migraine, abdominal pain, cyclical vomitings, all this associated with the migraine. So that is childhood periodic migraine. So now if you look at each one of it, the first one is retinal. The blindness will be occurring less than 1 hour after the onset of headache. In the V, vestibular, it is associated with vertigo. B, basilar, associated with brainstem symptoms like diplopia, ptosis, vertigo and all. And O, ophthalmoplegic. 3, 4, 5 palsy. Hemiplegic, there will be hemiparesis after the onset of headache. And CCC, the first is complicated. It is associated with seizures, unusually long and frequent. The second is catamenial, associated with menstruation. And the third is childhood. The person will be having abdominal vomitings, pain and all from the childhood itself. So coming to the pathogenesis, it is all because of this neuronal hyperexcitability. So this neuronal hyperexcitability will cause this neurogenic inflammation and neurovascular phenomena, right? So the three things which are involved in this pathogenesis is, first one is genetics. If the mutations in any calcium, sodium and the potassium channels, it can predispose them to the migraine. So these mutations in the potassium channels are called as TRESC mutations, in sodium channels called as SCNIA mutations, and in the calcium you just write P by Q type or alpha 1 mutations, right? So this is about genetics. And the second thing is hormones. So females undergoing this menstrual cycle, or if they are using any OCP pills, it will also trigger this migraine attacks because of this hormonal changes. And the third one is cardiac stents. So you have seen in the classical type of migraine, they will be associated with aura, right? So usually this PFO, AST and the AVM are associated with classical type of migraine. So this cardiac stents will also predispose the patients to the classical migraine attacks. So now let us talk about the theories of migraine. There are 4 theories. The first is neurogenic, dopamine, serotonin and the vascular theory. Coming to the neurogenic theory, what is happening here? First there will be activation of trigeminal nucleus. So after this trigeminal nucleus gets activated, it will cause release of CGRP. So CGRP is released. So after the release of CGRP, it will cause this inflammation of meninges and vasodilatation. As I have said before, aura is caused by vasoconstriction, whereas this headache is caused because of vasodilatation. So this typical vasodilatation and the inflammation will cause this unilateral pain. So that is migraine for you. So in the neurogenic theory, there will be activation of trigeminal nucleus, which will cause CGRP release at the nucleus terminals and which will cause this painful meningeal inflammation and the vasodilatation. So that is the neurogenic theory. trigeminal nucleus, which will be releasing CGRP, which will be causing inflammation and the vasodilatation at the meningeal site. Now coming to the dopamine theory. So it's nothing but the people with migraine will be having dopamine receptor hypersensitivity. That means the people are hypersensitive to dopamine receptors, right? And now let us talk about this serotonin theory. It is seen that people with migraine will be having low levels of serotonin. So this low levels of serotonin will be associated with migraine. And then last, the vascular theory. As I have said before, aura is associated with vasoconstriction and headache is associated with vasodilatation. So here aura, vasoconstriction of intercerebellar arteries and vasodilatation of intracranial blood vessels, right? So these are the four theories: the neurogenic, dopamine, serotonin, vascular. So in the dopamine, the people are hypersensitive to dopamine receptors. In the serotonin, low levels of serotonin will trigger this migraine attack. And vascular, aura will be vasoconstriction, headache will be vasodilatation. In the neurogenic theory, activation of trigeminal nucleus, which will cause release of CGRP, which will cause inflammation and the vasodilatation. So this is about the four theories. Now let us see the precipitating factors. So it can be caffeine, coffee, or cheese, chocolate, alcohols, OCPs, menstruation, any sensitivity to loud noises, glaze and lights, so excessive stress, lack of sleep, and the physical exercise. So now if you look at the clinical features, it will be hemicranial, that is unilateral, throbbing, pulsating headache. It will be severe intensity throbbing, pulsating headache, right? So associated with vomiting and nausea and also photophobia. And the scalp is tender to touch. So the scalp, when you touch it, it will be tender, it will be painful. So it is known as allodynia. The scalp is tender to touch in case of migraine. It is known as allodynia. And aura is present in case of classical migraine, which will be seen in about 20 to 30% of migraine population. So in the aura, they will be having this malaise, irritability, behavioral changes, and also focal neurological symptoms. So what do you mean by focal neurological symptoms? So basically this aura is of three types, okay? The first one is visual aura, second is sensory aura, and the third is language aura. Out of these three, the most common type of aura is visual aura. You might have heard people saying, like whenever they are having the migraines, they will be seeing some spots or flashing lights or shimmers kind of thing, right? So it is nothing but visual aura. So this, in the visual aura, they will be seeing fragmentation of images, flashing lights, scotomas, shimmering, and the fortification spectra. Now in the language aura, the patient cannot speak, so there will be transient speech disturbance. In the sensory aura, the patient will be feeling this tingling and numbness sensation in one part of the body, and then he feel like it is moving to other part of the body. So tingling, numbness for 30 minutes for one part of the body, and then it moves to other part of the body. So maximum it lasts for like 60 minutes, and then later it is followed by headache in case of classical migraine, which is seen in 20 to 30% of the population. Now if you look at this diagnostic criteria, this headache will be unilateral, it will be throbbing, it will be of severe intensity and aggravated by head movements. So if any two of these are present, it will be migraine. And also nausea or vomiting and photophobia. If any one of this is present, it will be migraine. So this is the diagnostic criteria. Now coming to last part of the video, which is treatment for migraine. You can give in two situations. One is for the acute attack of migraine and second is drug prophylaxis to prevent the further attacks of migraine, right? So under acute attack, again you will give them non-specific treatment and the specific treatment. So under non-specific, you will be giving this NSAIDs and antiemetics. NSAIDs will decrease the pain. So you can give them aspirin and the paracetamol. And antiemetics will decrease the nauseatic feeling and the vomiting. So you can give them metoclopramide and domperidone. And if still the pain is persisting, still the patient is not relieved by this migraine headache, you can go and give them specific therapy for this migraine. So the specific medication will be triptans, CGRP antagonist and the serotonin agonist. So coming to the triptan, you can give sumatriptan 50 to 100 mg tablet. So before we talk about the actions of triptan, let us re-revise this neurogenic theory. So in the neurogenic theory, first there will be activation of trigeminal nucleus, which will release the CGRP at this nucleus terminals, which will cause this meningeal irritation, inflammation and the vasodilatation, which will lead to unilateral severe intensity headache, right? So the triptans will be inhibiting every single one of it. So it will inhibit this release of CGRP, it will cause inhibition of activation of trigeminal nucleus, it will also inhibit this vasodilatation and the inflammation of meninges. So that is why the triptans can be given. And the contraindications of triptans are also important to remember, because it inhibits this vasodilatation of meninges. It will cause vasoconstriction. So this vasoconstriction is not favored in some conditions like stroke, ischemic heart disease, CAD risk and pregnancy, hemiplegic or the basilar type of migraine. Now coming to the CGRP antagonist. So we have seen this CGRP will cause inflammation and the vasodilatation. So this To antagonize the effect of CGRP antagonists, we're gonna give them erinumab and the fremanezumab, right? Remember this erinumab, which is CGRP antagonist. Last is the serotonin agonist. So in the serotonin theory, we have seen people with migraine will be having low levels of serotonin. So to boost that up, we are going to give the serotonin agonist like lasmiditan, right? So this is about the specific treatment. Now let us talk about this drug prophylaxis to prevent the further attacks of migraine. Drug prophylaxis is indicated when there is more frequent migraine attacks or more extreme migraine attack and aura for the long time, and if the patient is willing to take this drug prophylaxis, and also if it is causing migraine disability. In all these conditions, you can give them drug prophylaxis. So what will you do in this drug prophylaxis? You are going to give them ABCDs. A for anticonvulsions, B for beta blockers, C for calcium channel blockers, and the D for antidepressants, tricyclic antidepressants. So under this anticonvulsions, you can give them valproate. In beta blockers, propranolol. Calcium channel blockers, verapamil. Tricyclic antidepressants, amitriptyline can be given. If you want to remember, you can remember the dosage also. So 800, 100, 10 and 10 mg. So this is the dosage. So this is the drug prophylaxis. So anticonvulsions like valproate, beta blockers like propranolol, calcium channel blockers like verapamil, tricyclic antidepressants like amitriptyline can be given in the drug prophylaxis. So now coming to the complications of migraine, you have to remember two things. One is aura without infraction and second is aura with infraction. So what is happening in the aura without infraction? So first there will be aura. So normally what happens in the classical type, first there will be aura followed by headache, right? But what is happening in this aura without infraction? There is only aura for 1 week. There is no headache and there is no further development of infraction in the brain. So that is aura without infraction. Only one aura present with greater than 1 week. So that is aura without infraction. So in that cases also you can give them drug prophylaxis, right? So aura, severely long aura, you can give them drug prophylaxis. Coming to aura with infraction. So normally what happens in the classical type, first there will be aura, second there will be headache, right? But here it goes a step further and it causes infraction in the brain. So there will be aura present, headache present, and infraction is also present. So that is aura with infraction, migraneous infraction. So in the classical type, infraction is seen in the brain following the migraine. So that is aura with infraction, right? Coming to the third one, which is migraine with aura may trigger seizures. So that is a complicated type of migraine. And the last one is status migrainosus, so which lasts greater than 72 hours. So this migraine attack lasting greater than 72 hours is called as status migrainosus. So these are the different complications of migraine. So this is about it. Bye.